Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's a pleasure to be with everyone today. I see we've got lots of people online for this particular session, and I'm super excited about it. So this session is titled Data Informing Healthcare, and it is our second Igniter session of the conference. Today's moderator and organizer is Sara Hallvik from Comagine Health. So let's go ahead and bring Sara to the stage. Sara, time is yours.
Thanks, Norm, and hello, everybody. Good day. My name is Sara Hallvik. I'm the Vice President of Data Solutions at Comagine Health, and am thrilled to serve as your organizer and moderator for today's session that is called Data Informing Healthcare. So we've got two great presentations about different aspects of how data can inform healthcare and make it better. So without further ado, would like to introduce Kimi, Landry, and Megha from the Center for Improving Value in Healthcare, Civic, presenting on the effects of COVID-19 on cost and utilization in end-of-life care. Kimi.
Good afternoon, everyone. I'm Kimi Landry. I'm a research and evaluation analyst at Civic. Today, my colleague Megha and I are going to be discussing the effects of COVID-19 on healthcare costs at the end of life in Colorado during 2020 and 2021. So a little bit about Civic. Civic is an independent nonprofit providing unbiased data and resources to improve health outcomes across Colorado. As the administrator of the Colorado All-Payer Claims Database, or COAPCD, we maintain over 1 billion medical, pharmacy, and dental claims from 49 commercial insurers, including Medicaid and Medicare, covering more than 70% of Colorado's insured population. The COAPCD does not include claims from ERISA-covered self-insured plans, TRICARE, Indian Health Service, or uninsured individuals, which leaves gaps in the overall coverage of Colorado's population. So a little bit about end-of-life care. End-of-life care refers to the support and medical care given surrounding death. This care often spans days, weeks, or months before death as individuals manage chronic illnesses. Civic has focused on improving end-of-life care since 2009. Our goal is to guide discussions on serious illness and advanced care planning. And today we present a cost comparison between COVID and non-COVID-19 years for end-of-life care. So what we know from literature so far, previous studies have found disparities in end-of-life care. For instance, care intensity and access to hospice services is varied by insurance type. The pandemic exacerbated racial disparities in care, making these findings especially relevant today. So our study really examines healthcare costs for Coloradans who passed during the COVID-19 pandemic. Specifically, we looked at three things. How did demographics impact costs? How did costs for COVID-related deaths differ by payer type? And how did dual eligibility for Medicare and Medicaid affect these costs? I'm going to pass it to Megha now, and she's going to go over a bit of the methodology and results.
Thank you, Kimi. So methodology. We conducted a retrospective analysis of medical and pharmacy claims from the COAPCD for individuals who died in 2020 and 2021. We excluded traumatic deaths and those with fewer than 6 months of insurance eligibility before date of death. Our final study cohort was 51,559 distinct COAPCD members who died in 2020 and 2021. Outcome measures. We calculated cost on a per member per month PMPM basis to standardize comparisons. We then stratified the data by key demographics such as age, race, insurance type, and dual eligibility to identify patterns among them. Demographic statistics. A large portion of our cohort, 59%, was over 75 years old. 65% were non-Hispanic whites. This aligns with Colorado's demographics, but represents only the insured population. In our study cohort, 11.9% of individuals died from COVID-19 in 2020 and 2021. The percentage of deaths due to COVID rose slightly from 11.5% in 2020 to 12.3% in 2021, with a total of 6,110 deaths overall during this period. COVID-19 deaths by race and ethnicity, when we look into it, disparities became evident. Non-Hispanic whites made up the largest proportion of deaths. However, minority groups, particularly Black and Hispanics, experienced higher relative mortality rates, reflecting broader inequities in healthcare access and outcomes during pandemic. COVID-19 disproportionately affected older population in our study. Most deaths occurred among those over 75, reflecting the vulnerability of this age group. However, we also saw an increase in percentage of deaths among younger age groups between 2020 and 2021. This is likely due to factors such as delayed vaccine access and shifting patterns in the spread of the virus. Healthcare cost analysis is calculated as PMPM. In 2020, were generally higher for members dying of COVID when compared to other causes of death. This can be seen across all payer types, with commercial plans seeing the highest cost. Similarly, in 2021, these costs increased further across all payers, reflecting the ongoing financial burden of the pandemic. Commercial insurance remained the most expensive, while Medicaid and Medicare also saw significant rises in per member per month costs. Payer statistics. When we break down COVID-related deaths by payer type, we see distinct patterns. Commercial plans had fewer deaths overall, but contributed to highest per member per month costs. In contrast, Medicaid and Medicare saw more deaths, but the cost per member was generally lower. These differences highlight the varying financial impacts on different payer systems during the pandemic. Dual eligible individuals, those who enrolled in both Medicare and Medicaid in the same time, saw a sharp drop in COVID-19 deaths from 46.6% in 2020 to 25.1% in 2021, while the vaccine rollout played a major role in this decline. Increased Medicaid enrollment during pandemic emergency may have also contributed by providing broader access to healthcare and resources for vulnerable populations. Finally, we also looked into member healthcare coverage months. Commercial plan members typically had shorter coverage, averaging 2 to 4 months per year, while Medicaid and Medicare members had longer coverage, averaging 9 to 11 months per year. This indicates that individuals with public insurance had more consistent healthcare access leading up to their deaths. Commercial plans were only used as high-cost supplemental treatments. Now I will hand it over to Kimi.
Thanks, Megha. I just want to introduce a few of our limitations that we discovered during our study. First, COVID-19 deaths may have been classified differently across jurisdictions, leading to inconsistencies in the data. Second, the COAPCD only includes the insured population, which limits the generalizability across the nation. And lastly, race and ethnicity data are reported by payers and may not always reflect how individuals self-identify, contributing to potential gaps in understanding disparities. And in summary, in our key takeaways, COVID-19 increased end-of-life costs across all payers, with commercial plans hit the hardest. Disparities in care remain, especially for vulnerable groups. More resources are needed for end-of-life care in future pandemics to reduce inequities and financial strain. These are just some of our references. And last, I wanted to share with you the QR code for our abstract. And Megha and I really want to thank you again for your attention. And yeah, we look forward to taking your questions. Thanks.
Thank you.
Thanks, Megha and Kimi. And Megha, thank you for fielding all questions on behalf of your team. So audience members, please share your questions and comments in chat. We have a few minutes now to address those specifically. And maybe I can just kick it off with one question for you. I think including the death data in with the all-payer claims data is very cool, because that is not information that could otherwise be pulled from an all-payer claims database on its own. I'm wondering if you could describe a little bit more about the death data source that you used and how you linked that with the all-payer claims data.
Thank you, Sarah, for the question. And yes, we did reach out to the Colorado Public Health Department, and they were very kind enough to help us with this project. So what we did is we used their vital statistics death file data to pull in the COAPCD members to figure out then their healthcare utilization and cost. What we initially did, we sent them a large data file with all our member records. Anybody who is 18 years or older at January 1st, 2018. What they did is they did the matching on their front with multiple stepwise, like the full name, last name, SSN, date of birth. And once that was done, they sent us the file back again. And we did a second match with our COAPCD database to pull in the total members, distinct members in COAPCD. So this is how we receive death file information, such as the causes of death and other aspects, like if they were a part of hospice care or not. So, and the manner of that as well, like sometimes accidental or suicidal was also mentioned separately. Lastly, the way we used the data between the CDPHE and Civic is we use something called SFTP, which is Secure File Transfer Protocol. So we have a contract with them. We send them a data in a very encrypted format and received in the same way. So this steps eliminates any mishandling of the PHI data, and so that we are in regulations with all HIPAA and RRB rules.
That's great. Thank you. I had another question for you, which is around the race and ethnicity data. I saw you had split out many of your results by race and ethnicity. And I'm wondering if that data came from the APCD or from the death record, or how you decided.
So APC, as in we use race and ethnicity data from APCD database. So APCD receives race and ethnicity from payers. And as most of us know, based on the OMB regulations, Hispanic indicator is the only indicator which is the compulsory variable. Rest all race and ethnicity are self-reported. So although they might not be correct race and ethnicity, but this is the best match which we could get. Similarly, we could have received race and ethnicity data from that file. They also use it either with the patient's data file, healthcare data file, or they use the coroners, use their objective reasoning and then put race and ethnicity in the death file. So that is also not exact match, and hence we didn't ask the race and ethnicity information in the from CDBHE. So for this project itself, we have used CAPCD claims database to pull their race and ethnicity, and we have used Civic's algorithm to pull them into 7 or 8 groups, which you see on your on in our analysis, like non-Hispanic whites, non-Hispanic blacks, and then there are 2 or more races. Or when we could not pull them into any race or ethnicity, we pull them into an unknown race and ethnicity. So that's how you see the after whites, you have the largest population which we have is unknown race and ethnicity.
Great, thank you. And I see we have a couple more questions in chat, and I'm actually going to move us on to our second presentation now, and we'll have some time for more Q&As with all of our presenters at the end. I think those other questions might be relevant to both presentations. Thank you, Megha.
Thank you.
I wanted to, now move on to our second presentation, which is called Using Quality Data to Increase Chronic Kidney Disease Screening in a Primary Care Clinic. Ann Jensen and Jenny Lingle are presenting from Comagine Health. Take it away.
Hello, welcome to our presentation, Using Quality Data to Increase Chronic Disease Screening in the Primary Care Clinic. My name is Jenny Lingle. I'm the Senior Improvement Advisor and the Idaho State Director for Comagine Health. I'll be presenting today with my colleague, Ann Jensen, our Healthcare Data Analyst. So our objectives for today is that you understand the importance of screening for CKD, why we decided to focus on this for quality improvement, and to show you how collecting quality data, analyzing and displaying it clearly can help really drive meaningful quality improvement in a clinical setting. So why CKD screening? Why did we even decide to focus on this? So in the United States, there's over 80 million people at risk for chronic kidney disease, or CKD. 30 million people actually have it, but only a small percentage of those know they have it. And nearly 40% of patients with CKD stage 4, which is the stage right before end-stage dialysis, aren't even aware that they have it. So out of all of the people that have chronic kidney disease, uncontrolled diabetes accounts for approximately 40% of the cases, and then another 35% are from uncontrolled hypertension. So how do we catch this? How do we do better with CKD? The main thing is screening early and often for patients that are at high risk, mainly those that have diabetes and hypertension. And the two main tests for CKD are the urine albumin creatinine ratio, or UACR, which is a urine test that can be given in an office setting, and then an estimated glomerular filtration rate, or EGFR, and that is a blood test. And an EGFR is part of a basic or comprehensive metabolic panel, which gets done on almost anyone who goes in to see a provider. So out of those two, the EGFR is typically done quite often. It's the UACR that gets missed. But the UACR is the most reliable screening test because it tells the provider how quickly the kidneys may be progressing towards end-stage renal disease and what risk a person might be for higher events of cardiovascular disease. So that should really be done at least yearly in patients with diabetes or hypertension. So now I'm going to next talk about the CKD screening pilot that we did. It started in January of 2023 and went to July of 2024. We worked with an outpatient primary care clinic that serves just geriatric patients aged 60 and older. It's an independently owned clinic with one medical doctor who's a board-certified geriatrician and 4 nurse practitioners. The quality improvement team that we worked with was the medical doctor, the clinic manager, and the MA that works with the doctor. And the population of focus were patients with hypertension at their clinic. So this clinic approached us at Comagine Health and said, you know, we think we have a problem with our hypertension patients. We don't think that we are screening them adequately for CKD. Can you help us with that? So we quickly realized that they were unable to pull their data because they were working in an unsupported version of their EMR. So we executed a business associate agreement with them, or a BAA, which allowed us to set up a secure patient portal that we could share patient data with them directly. We then provided them a template for manual data pulls and entry and helped them do some manual data review so that they could set up their data for a baseline. So after they did that, they submitted their data through the secure portal, and our analyst, Ann Jensen, reviewed the data to establish a baseline. And when she did that, we found that only 7% of their patients with hypertension were being adequately screened for CKD with those two tests that we talked about, the UACR and the EGFR. And that confirmed that there was a quality issue, and we were able to begin quality improvement work in PDSA cycles with the clinic. I'll now turn it over to Anne, who will discuss a little bit more about the data and how we use that to drive quality improvement. Anne?
Thank you, Jenny. So this diagram that we see on the screen represents the monthly cycle that we had with the clinic throughout the time period that we worked with them. So every month we would receive data from the clinic. I would analyze the data and put it in a report and create a detailed patient list that we then shared back with the clinic. And then we would all come together once a month to review the data in the context of the clinic's quality improvement efforts. And we really like to celebrate the improvements and then discuss next steps by focusing really on what practical improvements can that clinic make and implement in a month's time? And then over the next month, the clinic would work on implementing those discussed changes, and the cycle continues. So one of the main measures that we tracked and included in reports was the number of patients with hypertension that were screened for CKD. For the purpose of the quality improvement project, we put patients into 3 categories. No labs, meaning that they haven't had an EGFR or a UACR. Partial labs, meaning that they've had one of the 2 labs. Most patients fall into this category, which you'll see by that line at the very top that's kind of a teal green. We see over half of patients falling into that category. And then full labs. These are the patients that have received both an EGFR and a UACR and are considered to be fully screened. Now, as Jenny said, we established that at the start of the pilot, only 7% of their patients with hypertension had been fully screened for CKD. So as the pilot progressed, the clinic implemented interventions, and we were able to observe the impact of those changes in the data. Some changes of note were in August, they started collecting urine samples in the clinic, and we saw an increase from 8% of patients screened in August to 14% screened in September. And this change really marked the start of a steady increase in screenings for the clinic. In September, the clinic upgraded to a supported version of their EMR so that staff and doctor were all on the same version, seeing the same thing. And this is when we started to see an increase in patients that had a CKD diagnosis. And then in December, they coordinated with a lab to create a combined lab test so that they didn't have to put in an order for an EGFR and a UACR separately. The clinic also started doing active outreach, which we'll talk about next, and also put a heat map throughout the clinic so that CKD screening and diagnosis was really at the forefront of their mind no matter where they were in the clinic. So as Jenny stated earlier, a majority of patients receive the EGFR at some point, meaning that most of the patients are in this partial lab category. In an attempt to help the clinic prioritize patients, we categorized the EGFR and UACR values of those patients that had one of the 2 tests. And then we provided that information in a detailed list to the clinic. This allowed the clinic to really start doing active outreach to those patients that had a decreased EGFR or an increased UACR to get them in to get full labs and hopefully catch a diagnosis early. So the clinic, thanks to the data, was able to move from passive outreach, just getting labs when people came in on their own, to active outreach. Another way that we used the data was by creating the heat map that you see on the screen, which was modeled after the KDIGO heat map to categorize patients that have been fully screened and identify recommended intervention decisions. This heat map was well received by clinic staff and allowed them to quickly identify if any patients with full labs fell into an intervention decision requiring a diagnosis. As a result, 12 patients were newly diagnosed with CKD. Additionally, when we were discussing the heat map and seeing the many patients that fell into that one monitor category, we helped uncover that the provider had ambivalence about diagnosing stage 1. We were able to address this and also carry it over into other projects that were focused on CKD screening and diagnoses. And lastly, using the heat map, we were able to confirm the progress of their KeyY project by seeing fewer patients in categories that might need a diagnosis and more patients moving in that correct direction of having diagnoses documented. So in conclusion, we were able to use data to drive and track improvement in many ways. By raising awareness of how many patients are hanging out in that partial lab status, we saw fewer patients leaving the clinic with only one lab each month. By the end of the project, this clinic saw a 400% improvement in the screening rate of patients with hypertension for CKD, increasing from 7% at the beginning of the year to 38% screened over the course of the year. In patient numbers, this is 91 patients with hypertension that are now fully screened for CKD. This resulted in 12 new patients being diagnosed that would have otherwise likely gone diagnosed until it progressed to a later stage. Lastly, we saw this clinic increase their capacity for their own reporting of data and quality improvement implementation. Now, I know we covered a lot of information in a very short amount of time, so if you have any questions, please feel free to reach out to Jenny or myself using the information on the screen. Thank you.
Thanks, Jenny and Anne. Fascinating pilot project, and it seemed to have great impact and benefit to the clinic you were working with. And that was actually the question I wanted to start with, was you called this a pilot project. Wondering if the pilot has ended, and if so, if the work has continued with or without your involvement, or how you were thinking about sustainability of some of the changes that you helped this clinic implement.
Yeah, thanks for the question, Sarah. So the pilot project has ended. The clinic was able to sustain this work by creating a report for MIPS. Before we ended the project, we helped them create a MIPS report that was close to the data that we had been taking from them and putting together and reporting back to them. So now they have a way to run their own report for this measure and to follow it. They also, like we mentioned, upgraded to a supported version of their EHR and was working with a private consultant on maximizing the function of their EHR so that they were able to pull their data more readily. They continue with this work and continue to see a lot of improvements. We at Comagine Health were then able to move on from this first project that we did and implement some of the things we learned from this clinic in some other CKD work with other organizations.
That's fantastic. Thank you. We have a question in chat about how expensive are these tests? And have you considered calculating a number needed to treat? This comes from Henry Stoddard.
Yeah, great question. So the two tests, the EGFR and the UACR, are very basic laboratory tests that have been around forever. So they're not very expensive. They're covered by, for the purpose of our work, Medicare, fee-for-service Medicare, especially when they're tied to, a specific diagnosis like CKD and diabetes. There are specific levels for treatment, and there's a lot of information, evidence-based information out there about that. We compiled all that information into one heat map for our clinics. So it had, the heat map had like diagnosis codes, the stage of CKD based on both the UACR and EGFR values right on the heat map, along with recommendations for how often that person should be screened. So for example, based on what stage they're at, they might need to be screened more often than once a year. They may also need a referral to a nephrologist. And all of that was found on one heat map that we created as part of this project.
That's great, thank you. Betty Harney shares in chat, inspiring story of defining, measuring, and reporting quality improvement metrics. That's not easy. Thank you for sharing. Anne, I think I had probably a question for you on data validation. So I know you mentioned in the presentation that the clinics were doing some manual data entry, which is prone to entry error. Can you describe a little bit about the data validation that you did?
Absolutely. Yeah, and that's why we're very excited that they are moving into the realm of MIPS, where they don't have to do any manual data pull. So it was, a little tricky because they got a template Excel spreadsheet from us where they were pretty much whenever a patient got a lab, they were updating it in the spreadsheet, doing chart review for the patients, which is very prone to a typo. They're very busy professionals. There's very few of them in this clinic. And so every month they would give me the data, and I, after a couple months, had developed a very nice, smooth process that was moving a lot faster. But I would always check to make sure, that patients' numbers weren't changing too drastically, or like there weren't duplicates. There were a couple duplicates that showed up in the end. An example of one scenario where we saw an error in the data, it was a really nice opportunity for us to talk with the clinic and have them kind of own the data, which I think is really important. They had entered, I think maybe it was like a 1 digit, I can't remember exactly, but it was a very alarming value for one of the two tests, and it was drastically different from what it had been before. Their values were very normal, and so being able to catch that and bring it to the clinic and talk to them about whether, is this what it is in the chart, or is it just like that in the Excel spreadsheet, and kind of putting that ownership on them to like look it up in real time in our meeting and say, oh no, like I just was busy and I entered it in wrong. We also were able to catch an individual that had very alarming values and really needed a diagnosis that the doctor actually thought they had already had a diagnosis. And so that was another kind of more positive side of the data validation, is they were able to catch something that they hadn't realized they hadn't entered into their medical record.
That's great. And I can imagine too that if you engage the clinic in owning the quality of their data, that ownership mentality carries on to when they have a more automated process to work in. If they're working in a MIPS system now, that ownership of data quality probably doesn't fall away very quickly. Yeah, thank you both. I wanted to invite Megha to join us back on stage. So audience, if you have questions for any of the panel or any individual presenter, please go ahead and pop that into chat. And I did want to come back, Megha, specifically to a question in chat about why are commercial COVID deaths higher than those, or lower than those of Medicaid and Medicare?
Yeah, thank you for the question. And this is really interesting because how we format our study of the cohort population. And since we are looking into the end of life population, we knew that we would be looking into largely into geriatric population. So we knew that the population would skew more towards Medicare fee-for-service or dual eligible populations. And that's what we are seeing in our database as well. And like how I mentioned in our race and ethnicity breakdown, and when we were looking into different payer breakdown, that the commercial payers were only used as a supplemental for any high costing utilization. So if Medicaid and Medicare or their primary insurance is not able to cover that's when I think we think as an assumption is that the commercial payer comes into play to capture or to cover up all and any other high costing healthcare needs of the patient during the end of life.
That's great, thank you. In Jenny and Anne, in your presentation, you were really focused on the Medicare fee-for-service population, and Megha, in your population, it was more of an all-payer environment, but included dual eligibles within that. And I'm wondering, maybe Jenny or Anne, you could answer this first, and then Megha, I'd like to hear from you. If there are special considerations for either the Medicare fee-for-service or the dual eligible populations as you're approaching studies like the ones that you presented on today.
I can go ahead. So in our study, we did look at the population as payer level. So we did see there was certain percentage of the population, especially in the Medicaid or those who were younger in the Medicaid or younger in the in the commercial payer groups, we were seeing them having high costs. So that's when we thought of using a dual eligible population as a separate group to see what this population is showing us compared to the payer per se. And that's when we remove dual eligible population from our cohort size to see differences or disparities among payers. That's when we realized that if Medicare fee-for-service and Medicaid were kind of having a consistently increased cost during COVID-19, but when you pull in the dual eligible populations, the utilization rates and the overall cost, which is per member per month, PMPM in our study, shot up quite significantly. And so we had to show dual population as a separate group and not as a part of Medicaid or Medicare together.
Yeah, Sarah, I think this is a really interesting question. So our pilot project was with a primary care clinic located in the community that only served geriatric patients. So not all of the patients were fee-for-service Medicare. Some of them could have been Medicare Advantage. For the sake of our work, as long as a provider sees Medicare fee-for-service patients, we can work with them. We try to design our quality improvement interventions and our data collection to be able to show improvement across all patients with a certain condition, knowing that in a clinical setting, a provider wouldn't change what they're doing based on a payer type. They typically do evidence-based best practice. So we implement our quality improvement that way. This office was different because they only see geriatric patients. I think the doctor at this clinic would say there's a lot of considerations for Medicare beneficiaries, including being able to follow them in a specialized primary care clinic reduces a lot of cost and can keep those populations maybe living independently longer. So that model is a unique model, especially in the area where this primary care provider practices. But for the sake of quality improvement and data collection, as long as a provider serving Medicare fee-for-service in their organization, we work with them and we try to design it so it can impact all of their patient population, not just Medicare.
That's great. Thank you. I love that focus on the community benefit, even with the focus on one of the more vulnerable populations. Megha, I think there's a question for you in chat here. Were you considering the cost paid by the insurance or the cost of service billed to the patient before insurance paid?
Thank you for the question, Donald. Yes, the COAPCD receives data from the payer. So it's the amount paid by the payer as well as the out-of-pocket paid by the member. So the total cost, which we calculate, is the sum of these two values. And it's not the service billed to the patient because we have not utilized that in our database. So we have just utilized the total cost of care, which includes member out of pocket as well as the payer amount.
Great, thank you. And I did want to go back to the question of data validity or validation of data. Jenny and Ann, you spoke about how you did that with your with the clinic and helping them increase the ownership. And I wanted to go back to a comment that Sylvia had in chat about validating race and ethnicity data specifically between an all-payer claims database and the death records, where the family does have the ability to correct or update the identified race or ethnicity. Megha, did you guys look at that at all?
No, sorry, Sylvia. Thank you for that suggestion. And we did get those suggestions for other stakeholders. When we had started this study, when we had pulled the death data file, we didn't anticipate that there would be so much of the variability in the race and ethnicity in COAPCD front as well as then the death file. And like I mentioned, there's been pros and cons to both of it, both the system, and it would be nice to have a validation done both on the death file. So maybe moving forward in phase 2, when we re-pull this data set again from CDPHE, we might request them to send the race and ethnicity data from the death file so that we can match with COAPCD.
Wonderful, thank you. We are at time, so Anne, Jenny, Megha, thank you very much for the presentations today and engagement from all of you audience members. I did just want to remind you that the full content of the NATO conference kicks off next Tuesday, November 12th at 11:30 Eastern for the opening plenary and keynote speaker to launch the rest of the main session. So look forward to seeing you then, and thank you.
Thanks, everyone. Bye-bye.